Hi, everybody. Hopefully the technology is now working. Sorry about the delay there.
Working?
I'm just letting people know they need to just join us on Facebook. There seems to be a lot of misunderstanding there in terms of things. When people are asking for the link, there is no link. It's on Facebook.
That's why you gotta it's got to dumb it down. Got to get it all down there.
I know. You'd be surprised how many, the number of times people have asked me about the time, Bill, and the number of times people have asked me for the link. It's just like, man, I tried to make the instructions as clear as I could, but that's okay.
I know.
That's okay.
We learn.
So, and I've still got people, it's just like, where is it live? It's like, it's live right here. So anyway, it's all good fun. Now, I'm just going to, just in case, I'm just going to start recording this as well, Bill.
Okay.
So that if technology lets me down, I've got a backup plan with everything.
Okay.
So, all right, looks like we are in business. Now, I just need to play with this a little bit so that I can hopefully see comments and so forth as we go. Which means I'll need to be on my phone at the same time. So apologies to everybody. That being the case, if I go into Facebook, it should say somewhere that we're live, somewhere.
So do you want to introduce me and then me start and then you just kind of jump in where we want to or what?
Yeah, absolutely. All righty. So morning for me and good afternoon to you and good evening to many other people wherever in the world they are. We nearly got to 1,000, Bill, Harrell, but I think we'd be pretty happy just shy of that.
Oh yeah.
So for everyone that's joined us today, thank you very much for coming along. My name's David McIntosh. I'm an ear, nose and throat doctor in Australia. Looking straight at me and yourselves, we've got Dr. Bill Harrell. Bill is an orthodontist from Alabama in the United States. Bill and I started chatting, must be around about 6 months or so ago, initially in the context of him. I think he just stumbled across my page and got my book, but subsequent to that, we've had a lot of good chats about a whole range of things and found that we're very like-minded and that Bill's got a huge amount of experience and knowledge that I'm just absolutely delighted to link in with and learn from. So Bill, I'll let you elaborate on anything else you want to do from the intro point of view. A lot of people online have already got a chance to meet you through what we've done already. And then the plan for today, guys, is that we're going to keep this very general. We have obviously focused on ENT being me and orthodontics being Bill. But that line in the sand of differentiation is something that we want to basically erase and highlight how coming together can deliver benefits in terms of what I'm trying to achieve and what Bill's trying to achieve. And ultimately, really, it should just be a common goal of achievement. It shouldn't be like we're trying to get one or the other better. It's a mutual benefit to each. So, Bill, if you want to take over from there, and if you have any problems sharing the screen or anything, I can fix that because I can just make you a host. There we go. You're in charge.
Okay. Is my screen on now?
If you throw it on to share screen, hopefully the technology will cooperate. We've had fun playing with this.
Do you see my screen?
I can't on mine, and I'm looking at Facebook, and it's not coming up there either.
Okay. Well, while you're working on that, I'll introduce myself. I'm Dr. Bill Harrell. I'm an orthodontist, board-certified orthodontist in Alabama, and I do TMJ therapy also. I do a lot of early kind of airway focused, looking at airway. Got interested in that basically about 1982 when the monkey studies came out from Harrell, and then Jim McNamara, who's an orthodontist and chairman at Michigan, did some monkey studies along with that, and it kind of got me thinking about that. So then about from 1978 to 1985, I was lucky enough to meet up with Dr. Bill Farah, who I think his daughter may be online right now, Marie, in Chattanooga, Tennessee. And Bill Farah and I, Bill was a pioneer in TMJ. He and Bill McCarty kind of developed some of the techniques to about the anterior displaced disc and the surgical treatment. So that kind of where I got my TMJ therapy from. And then dental sleep medicine just kind of has always been in my repertoire. And I got to, thank goodness I got to meet Dr. Christian Gimeno. I know Steve Schindel, who's the former chairman at Stanford plastic surgery there. So that's kind of where I got my sleep medicine or dental sleep medicine information from. Are you able to see my screen?
No, I'm looking at Facebook Live and it's not coming up. So that share screen function down the bottom middle there somewhere.
Let me look. Yeah, let me look. Hang on.
It's a green button on my screen.
All right, hang on just a second. Let's see. Now, I don't see a button on mine. So I do. Here it is. Yep. I got it.
You're in business. Then I'll ask you which screen you want to share.
Yep. Now see.
There we go.
That better?
That's us. There we go.
Okay. Now let me put it on slide. Well, that's us. Basically today, the topic is otolaryngology and orthodontics, working toward a common goal. And David and I I've got slides and he's going to pick in whenever he wants to. And we're just going to kind of talk about things and give you some, the thing that amazed me about David is when I got to meet him, I actually joined his Facebook page called ENT for Dental Practitioners. And I highly recommend you go there if you want to get voluminous amounts of evidence-based articles. He's got references that I don't think anybody else has, but anyway, he's got references that he puts out every day, I think, just about different things. So yes, he and I met and then talked a lot. So we've kind of had common goals here. That's what we're going to talk about today. One of the things we looked at is, orthodontists and really otolaryngologists ought to be tied at the hip. If you look at our kind of logo we got here, O2 is for orthodontists and otolaryngologists, and O2 is oxygen. So they kind of go together. We deal in the same area, the whole nasomaxillary, as Kevin Boyd says, the nasomaxillary respiratory complex. And it really is, orthodontists deal with this all day about craniofacial growth, especially in young children, and the tendency for that to potentially lead to problems later on in life. And if we can recognize these things early, shouldn't we be treating them early? So what do ENTs and orthodontists want? ENTs want kids to breathe properly, and orthodontists want beautiful smiles and faces. Like this child, if you look, you can tell he's got a problem, and he's actually got an airway issue. Hopefully, if we get time, we can get into this case later. That's something later on we can look at. But we do some 3D imaging of the facial scan, but you can see he's class 2, retrognathic, mouth breather, a lot of other things going on. But just to give you that, but why not have both? Why can't we have both while we're putting this together? So I think that's where the team comes in, to be able to take a child like this and grow them into somebody that it's a totally different child now. And his ADHD is gone. He had a lot of issues. He was making really bad grades, didn't care. All of a sudden, it's kind of like he woke up. He was almost at this point. This was the progress right before we putting on braces. We're waiting for some teeth some primary teeth to come out, but you can see the difference in the airway, and we'll talk about that later too. Here's a little cute video. . 'Cause It's one way to stop somebody from snoring, huh? And we all kind of feel sleepy during the day, so that's kind of like the little kitty cat. Now, this is a child that's 3 years old, and you think, what's orthodontics going to do for this child? But this one's been on Facebook all around, but his mother's a nurse. And if you watch him, he's sitting upright and awake is the interesting thing. But this is typically what happens with it. You usually got a retrognathic mandible, mouth open, mouth breather. You can see the cleft almost in the chin here where he's pretty much retrognathic. If I'm going to take this up a little bit, I'm going to let you listen a second. Hang on a minute. Getting kind of messed up here. But if we come up here, and what she does is she advances his mandible, you know, during that time. And if you look at him, his facial, the redness in his cheeks will go away. The important thing is quietly breathing. Even though his mouth's a little bit open, now he's breathing through his nose. So why don't we, as orthodontists especially, you know, we don't tend to treat kids too early. Kevin Boyd does at 2, or probably in utero. But this is the time to catch these things. Now, if we look back in history a little bit, the first report of a person having potentially sleep apnea was in 1836 by Charles Dickens. The posthumous papers, a lot of people already know this. The posthumous papers of the Pickwick Club. That's why they call it the Pickwickian syndrome. But it was about a little boy named Joe, this little fat boy who ate and slept all the time, always tired, and they considered him lazy. He'd actually just fall asleep talking to somebody. So this is kind of in the literature. In 1889, a pediatric surgeon, William Hill in Britain, was removing tonsils from a child with obstructive airways to alleviate their struggles with breathing when he noticed unforeseen effects of the procedure. The tonsillectomies unexpectedly cleared up the child's chronic headaches and problems paying attention in school. In the British Medical Journal, he noted, children, the victims of nasal and pharyngeal obstruction, frequently demonstrate a marked inability to fix their attention on their lessons and work for any length of time. Well, what is that? Well, that's what we describe now as ADD and ADHD. And they've actually accelerated in the children about the last few decades to an epidemic proportion, and for unknown reasons. Well, we may know the reasons now. We're starting to pick up on the reasons that these happen. This little information, interesting story about this. A friend of mine who I went to high school with in Columbus, Georgia, that's where I was born and raised. He and I got to talking one day, and I was telling him about this webinar. Hopefully he's on, Leighton Gordy. But anyway, he was telling me about his grandfather, who was actually an orthodontist in Columbus, Georgia. This was way before my time. But he actually graduated Maryland Dental School in 1897. He went to the Angell School of Orthodontics. Excuse me, and I got a hold of his papers. Now, this was about 1920. Nose and throat conditions and allied habits in relation to irregularities of the teeth and development of the jaws. A quote down at the bottom of this page, Dr. Edmund Kells of New Orleans wired him and said, "You have given the profession and the whole world something worthwhile. Don't be discouraged. Remember Jenner, Pasteur, Röntgen, and Wells. Ignorance and prejudice burned Savonarola at the stake," if you remember that. This was another little pamphlet that he wrote. He published it, Mouth Breathing and a Few Facts Seldom Discussed, around 1929, so 71 years ago. And in this book, he says 3 generations ago, now that's 7 generations ago, which is about 184 years, Charles Dickens pointed out the relationship between open mouths, backwardness, and delinquency that would have saved millions of lives and would have averted millions of life failures had the civilized world realized the true importance of his words. That's pretty powerful. I mean, that's pretty powerful. And this was back in 1929. It's interesting. Historically, they probably knew more about it than we did, for somehow we kind of tended to forget all this. The first mention of OSA was in 1965 in a paper. And then, of course, Dr. Christian Guilleminault at Stanford was one of the pioneers of sleep apnea. In 1972 was the first sleep clinic. And he discovered pediatric sleep apnea in 1976. That's right when I was in the middle of my orthodontic training at the University of Pennsylvania. Wish I had known him then. But he was convinced that anatomy has a lot to do with this and growth alterations. And he was convinced that early intervention, even at 2 to 5, I'm kind of 4 to 5. If I were Kevin Boyd, I could maybe treat 2-year-olds, but it could lessen the possibility and even eliminate OSA. These are the other major pioneers of sleep medicine. Guy up here on the is Dr. William Dement. He's considered the father of American sleep medicine. These are the primate experiments. A lot of people have seen this. I know there's different groups online. There's medical doctors. We've got medical doctors. We've got dentists. We've got allied healthcare professionals such as myofunctional therapists and speech pathologists, and we also have lay people on board. But what they did, they took monkeys and they stopped up their noses to see what happened. So they took young monkeys and stopped up their noses and had them breathe. They're an obligate nasal breather, but it created a mouth breathing monkey. And you can see, this is the normal, what it normally looks like on the left, but on the right, you see there's a lot of problems. There's crowded teeth, crooked teeth. Could that be a symptom of something going on? So the primate experiments reported as part of a series, the relationship between mouth breathing and dental malocclusions, that is between the deviations of the orofacial muscle recruitment and jaw morphogenesis. Mouth breathing was developed in these animals experimentally by obstruction of the nasal passage with silicone plugs. And the experiment showed the monkeys adapted to these, and it depended on how they adapted, whether they kept opening and closing their mouth or whether they actually breathed, but they all breathe differently. But in our field of dentistry, there's lots of different malocclusion types, and all sorts of malocclusions were created with these monkeys, not all the same thing, which that was very interesting to me back in 1981. So here's kind of that timeline of just these people, but starting in 1836, working way through to Dr. Perry Gordy in the 20s, up into the 70s with Dr. Guilleminault and others and the primate experiments. And you know, what does the future hold? To me, we kind of got to go back to the future, because it seems like these guys way back here understood these concepts probably better than we did. Now, they didn't have all the technology we have, and we've got a lot of different, quote, evidence-based articles that have come out. Some of them are not the best they are, but anyway, a lot of things going on. This was an important article that just came out in 2020 in the AJODO, in the American Journal of Orthodontics. And this is something that I show parents because it's the prevalence of and risk associated with potentially sleep disorder breathing in children. And I can't remember the number of patients that they researched, but almost 11%. So that's 11 patients out of 100. The prevalence of positive sleep-related breathing disorders was found to be significantly higher in the general pediatric orthodontic population in a than in a healthy pediatric population. So you got, I think it's more than that. In my office, I think it's up closer to 25 or maybe even 30%. The prevalence of snoring in these kids was about 13.3%. Sleepiness was almost 18%. And they had other comorbidities such as nocturnal enuresis, 13.6, overweight about 18%, and attention deficit hyperactivity disorder. Look at here, 31, almost 32%, 1/3 of the kids that come in your office as an orthodontist or dentist or whatever, a lot of them have ADHD. Well, we know that's kind of tied to the oxygenation levels or the breathing, the obstructed breathing that tends to occur in these children. And they had a higher prevalence in the orthodontic population with higher sleep disordered breathing risk at a confidence level of p-value of 0.05. So the conclusion is that the higher pediatric sleep disordered breathing risk prevalence in the orthodontic population compared with it was higher than the healthy pediatric. Orthodontic practitioners should make sleep disordered breathing screening a routine part of their clinical practice. There's a number of us that are on this Facebook Live today, Dr. Jerry Simmons, Dr. Dwayne Grummons, and others that are on here, and we're actually we've been asked by the American Dental Association to come up with some screening exams. And these are kind of what they look like. The first one is real easy. All we wanted to do was come up with, does your child have mouth open posture? Do they snore? Do they frequently have any of these potential symptoms? And do they have behavioral issues too? Because all these, it's a 5 questionnaire, real simple. Any healthcare professional can do it. And it is quick and easy, and it's not going to take a whole lot of time. Now, if the key, what we wanted to do here was any yes answer into this little simple 5 questionnaire elicits a little bit more specific. The first one is not specific. It's sensitive, but it's not specific. This gets a little bit more specific into those areas. We define kicking and sleepwalking and talking. Do they have noisy breathing during awake or sleep? So it gives us a little more specific things to look at. So we think that's something, and we're in the process of validating that right now. So if we look at the treatment team, we have a lot of people involved. The otolaryngologist, the ENT, that's where David and I've kind of clicked. The sleep physician, the pulmonologist, the pediatrician, family practice, neurologist, plastic and reconstructive surgery, and you can put a lot of probably other people in there. The dentist. We should be trained in dental sleep medicine. One interesting thing that happened, I think it was 2017 in Atlanta at the ADA meeting. I went to the reference committee there, and where the American Dental Association was coming up with their position paper on where dentistry should fit in to sleep-related breathing disorders. And a lot of discussion, and a lot of dentists got up and talked from the dental side. There was really only one guy there that was a medical doctor. His name is, it left me right now. But anyway, he was the previous president of the American Sleep Medicine, AASM, American Academy of Sleep Medicine. Nathaniel Watson was his name. He was previous president of that group. And he stood up not in favor of it. And the reason is, and I kind of agreed with him, he said, basically a physician goes to school for at least a year to become a sleep doctor, to be able to diagnose and treat with CPAP. Whereas dentists, our license gives us the right to take 2 impressions on a bite registration and send it off to a lab, and hey, we're a sleep doctor. Well, we're not. We need to learn what AHI is and RDI and the apnea and apopneas and all these. There's a lot of different type sleep disorders. I think David told me maybe there's 140 something different sleep disorders, but obstructive sleep apnea, of course, and upper airway resistance are probably the most common. So, and I went up after the thing was over to Dr. Watson, and I told her, I said, you're exactly right. So that's where the things like the American Academy of Dental Sleep Medicine, the AAPMD, which a lot of those guys are online now. There's a lot of training out there, and you need to be trained. You need to work with the medical side, because guess what? Sleep disordered breathing issues and sleep apnea, we're touching our toe over here in medical, and we got to be careful. We don't just need to take a bite registration and 2 impressions and, treat sleep, even snoring, because that's a whole nother thing that Dr. McIntosh can talk about. And then the other healthcare professionals too. There's a lot of other allied healthcare professionals that should be on board. So maybe we go from 2 monkeys to 3 monkeys, or maybe more monkeys. I don't know. But anyway, we should all work together as an interdisciplinary team. Now, if you go through history, what's some of the either cures or management of sleep apnea? And of course, the first one that came out was in the 80s, about 100% cure. You do a tracheostomy, you bypass. That's what they were doing with a lot of the morbidly obese people, because they didn't really have any other way to do it. And then you've got CPAP came on the scene about 1981. Its management, it has about a, the effectiveness is about 95% plus, maybe even 100%, but about 48 to 50% of the patients don't wear it properly, effectively. And the interesting thing is success is defined as 4 hours a night for really only 4 or 5 days a week. So they're not wearing it all the time. And then the oral appliance therapy, or the other is maxillomandibular advancement surgery with genioplasty. It's almost a cure. When you move the upper jaw forward and the lower jaw forward and the chin with the tongue attached forward, everything's coming forward, not backward, you pretty much can cure sleep apnea. So these 2 are about the cures, but nobody really wants to do the first one, even the second one. You got oral appliance therapy, which is what we deal with. You got a high cooperation level, but it's not quite as effective. But its success is different. 8 hours a night, 6 days a week is kind of the definition of success for that. So the goalposts are different here. Effectiveness increased with a thing called matrix system. Dr. John Rimmers invented this. It's something it's auto-titratable, kind of a temporary oral appliance that's auto-titratable during the polysomnography to come up with what is the best mandibular position, the vertical plus the anterior posterior position of the mandible. And probably the best thing, if you can ever get it covered by insurance, is a combination of CPAP. CPAP blows the air it blows the air open with air, but the oral appliance physically dilates the airway. So sometimes I've got people that really have a great success with that. Steve Carterson came up with this. I hadn't really heard about this, but there's about 1.7 million PAPs sold in the United States. 820,000 of them are abandoned. So the success rate's about 52%, 48% of them are abandoned. And there's only about 110 claims for EO486, which is the oral appliance for sleep apnea. I thought those figures were kind of interesting. So about 13.4% of the people actually abandon this. And there's a huge difference between this number and this number. These people that have abandoned or intolerant, they should be, maybe they get some other kind of therapy, but a lot of them probably should be looking at a oral appliance therapy, maybe on some of those. Now, the other is something that Dr. Gimeno talked about a lot about obstructions. Of course, adenoids and tonsils are about 60% of the problem. Turbinates about 18%, deviated septums, sinus inflammation such as allergies. All these improve, and a lot of them improve them a lot once these things are taken care of. Even the openings of the nose, when the opening of the nose is small, the child can't breathe through the nose. Early dentofacial growth therapy. This is something that Dr. Gimeno talked about a lot, as far as a significant improvement, if not a cure, but early growth guidance. I mean, early as you can get, as you feel comfortable treating these, to do some early dentofacial orthopedics, myofunctional therapy, habit correction. And in my mind, what does this do? It mimics MMA surgery or mandibular advancement surgery. So if this is a major fix, so to speak, for people that have obstructive sleep apnea, why wouldn't it be something that we try to mimic in our children? And you got to do it early. You can't do it at 12 or 14. You got to do it, believe it or not, at 5 years of age, 50% of facial growth is complete. By 8 years of age, 80% is complete. And by 12 or 14, normal orthodontic age, 95% of their facial growth is complete. So no wonder we have to do some other kind of stuff on some of the orthodontic age patients. Expansion, early RPE, reverse face mask, functional appliance treatment, myofunctional therapy. In adults, you know, you've already got comorbidities now going on, but you can do a surgically assisted palatal expansion or bone supported palatal expansion, which actually increases the volume of the nasal cavity. And what the other thing you're doing is you're making room for the tongue, because the tongue has to get up into the roof of the mouth early on in life to function properly and actually help mold the upper jaw and lower jaw. So here's about nasal breathing. Nitric oxide's gotten to be a big thing now. It actually helps to increase growth hormone. Nitric oxide stimulates growth hormone secretion from the pituitary gland. Nitric oxide is found to increase growth hormone secretion. Nitric oxide is secreted in the sinuses and released with proper nasal breathing. And so you don't get nitric oxide release when you breathe through your mouth, or very little. It's a lot different. I had to bring this up because of the Australians out there. There actually is a study. It was done in 2006 in the British Medical Journal on the didgeridoo. We'll let David talk more about that, but it almost acts like a reverse CPAP, because you're having to learn how to what's called circular breathe. And they only used it 20 minutes a day, about 6 days a week for 4 months. So they had 25 patients plus controls. They took the AHI, the average AHI was apnea-hypopnea index. What that means is the amount of apnea is how many times they stop breathing. Hypopnea is how many times they shallow breathe and the oxygen level drops from 21 to 6.2. Now, normal is about 5 or less is what's considered normal, or the goal of CPAP to take it to. But that's still a 337% decrease of AHI. Epworth is a little screening device that asks certain questions. 24 is the worst you could have. Anything above eight questions out of 24 is a significant red flag. If it's over 10, it's 2 red flags. So those went from 11.8 to 4.4. So it was a 269% decrease there. There's another thing out there called Inspire, which is a genioglossus nerve stimulation, where they actually plant something under your collarbone. Part of a lead goes into your intercostal muscles, which are the muscles that contract breathing, and another lead goes to the back of your tongue. So you cut this thing on with a little remote control You don't have it going on all the time. You cut it on at night, go to sleep. If your tongue falls back, it sends a little electric current to move your tongue forward. You have to have certain criteria to be a candidate, but you can see there's a lot of different types of treatment out there. Now I'm going to end, I'm going to stop right here, and maybe David, and then we'll discuss a little bit. If we do have time, we can look at some case reports, which I have later.
That's excellent, Bill. I had so many times I just wanted to jump in there, but I'm just so captivated by what you've got to say. And for me as a medical person, it's really quite dumbfounding and astounding to have yourself as an orthodontist to be sitting there and talking about things like nitric oxide and growth hormone. And when I listen to this, I think you actually know a lot more about this than the medical doctors do. So whilst you might have been at that conference and the sleep medicine person might have been, the top of the tree, well, you've climbed pretty high up that tree yourself, and a lot higher, I think, than what a lot of medical doctors do. But you're absolutely right about education. But the problem is that we have this education silo, and the people that are really getting taught about sleep medicine ultimately are the sleep medicine doctors. If you have a look at the education and training programs in dentistry and medicine alike, so my time at university, so our university over here in Australia is a 6-year undergraduate program. So within that 6 years, I probably would have had maybe 2 hours on sleep. That's not sleep medicine, that's not sleep pathology, that's just on sleep. And when I was going through, sleep apnea wasn't even a topic of conversation in education. But in the scene really of the past 20 years, it has exploded by a huge amount. And I was lucky in that during my ENT training, one of the ENT surgeons that was working here had gone over to Stanford and worked with Riley and Powell. And he brought all that contemporary and cutting edge knowledge back to Australia. And look, we can see, it evolves and it continues to be refined. But I was just very, very lucky to be in that position. And then I went and did my pediatrics. And, the eye-opening thing there was that, all the sort of problems that we were talking about in adults, we were actually starting to see those in the kids as well. And just that light bulb moment of things. So what I thought I might do, if it's okay, because your talk is so fabulous, do you mind just rewinding the slides back? And I'm just going to make a few little comments that came to mind as we go, purely to just give everybody just a few sort of extra little bits and pieces on what you've already said along the way. And really, I mean, that'd be great. Thanks, Bill. So even that video that you showed of the mouth putting the finger in the mouth, I mean, it always amazes me when we look at the science and the research that's published. And one of the things that they report is, the questions they ask is, how many times do you sit by your child at night and see them stop breathing and then shake them? These are people that are seeing their children do these things, and they're not even, bringing it to the attention of medical people. And medical people aren't asking. So, this child that you showed this video of, I mean, this is just absolutely classic. You've got everything going wrong here. The mouth is open, the tongue is down, the head is tipped back a little bit, and this is the child sitting up. And as I tell people, if a child has their head tipped back, well, just rewind to when you may have done a first aid course, if you're familiar with doing mouth-to-mouth resuscitation. The thing that you do, other than in infants, is you tip the head back. And the reason that you do that is it opens up the airway. So these children are essentially doing first aid on themselves to try and stay alive. I mean,
that's just choking right there.
Yeah, he's choking, yeah. Yep. So to have so many parents see this and not know about it, but what I guess is the next level of concern is the ones that do worry about it and then are dismissed at the medical level because they don't have tonsillitis and all these sorts of things is really quite disturbing. So, and then if you just want to sort of roll forward onto your next slide there as we go, that was, it's just amazing. This Charles Dickens thing, that was my medical education. That was my introduction to this topic. That was, Joe the Fat Boy. That's what we were talked about in terms of, and we were only talking about adults in my medical education. We were not talking about children at all. And we were taught that adults, it's because they're overweight and they're obese, and that was it. There was nothing else entered into the equation. It really wasn't until well after I'd finished my training and it was into my several years of my career that even the fact that thin people could even have this. It's just like, how is that possible? How can their airways be compromised? The whole context and concept of jaw and skeletal deficiencies wasn't really in the mindset as to how that contributes to airway problems. So it really has been an excellent wake-up call for me, for those that can see what I just did there. And if you just jump onto your next slide as we go along, the whole thing that in 1889 that they were putting out tonsils and seeing the benefits in children, and that we've somehow disconnected from this and forgotten is really quite sad with regards to what it speaks about as a medical community, and especially as you've alluded to when I sort of share these papers, is just how prolific the information is around about the 50s and 60s, but as you've shown in the 20s in the dental literature. It's almost like the dentists were seeing these kids on a regular basis and just getting distraught with what was going on. And I think it's absolutely correct. I think we have over the course of this time period in history done a huge disservice to the public with regards to losing our interest and focus on breathing, which is a basic survival thing, and sleep, which is again is a basic survival thing. And if your sleep's not right and or your breathing is not right, the rest of you is not right. The knock-on effect from a health point of view and in a range of body systems is just unbelievable with regards to the problems that we can identify. And then if you just bounce forwards again for me there with what we were saying, 1965, they're starting to measure the brain. 1976, Guillemot is saying, look, we've got to sort these kids out. He's sitting there. How old would he have been then? 1938, 1976. So just over the age of 40. So younger then than what I am now. And pioneering the field and just going, look, these kids are in trouble, and they're not just in trouble because they're tonsils and adenoids, I think, which is your next slide from memory. Well, not quite. That's but this to me is the big one. This is the thing that I struggle to comprehend the discussions, and maybe it's an education thing, maybe it's just a perspective thing, but as I know and as you know, there's a huge amount of animosity and debate as to whether breathing patterns affect skeletal form and outcome. And those that claim that it do will refer to these Harvard studies, but then those who refute it will say, well, yes, look, out of those 14 monkeys, only 10 of them got the malocclusion, 4 didn't. So it doesn't, your hypothesis is flawed because it should have affected all of them. But that's the problem, is that that whole position is flawed, because not everybody that smokes a cigarette is going to get lung cancer. So we don't turn around and say, oh, well, your supposition's flawed. Not everyone's getting lung cancer, so smoking's okay. I mean, nobody in their right mind from a medical point of view would ever accept that proposition, but they will refute this paper because not every monkey had a malocclusion. And that's the whole thing about, in my mind, orthodontics, is I deliberately draw that relationship as a concept between orthodontics and cancer. And I do so because I'm not dentally trained, and that's to my detriment, but it's also probably to my advantage because my thinking isn't tainted or contaminated by paradigms. It's just sort of very a blank canvas, open slate, and really just absorbing the information and processing it rather than being told how to think. And, I think with orthodontics, there's absolutely some genetics. There's some genetics that will determine how those jaws and bones are going to grow. And then the environment will have an influence on how those genetics are going to be expressed. And I just can't comprehend why there's a resistance to accepting that we are dealing with the same kids. Even if we want to just have the line for the peace of mind and putting it all behind us and just saying, look, airway mode has nothing to do with how the jaws and teeth grow. But at the end of the day, we've got a huge number of kids turning up to ENTs that have got orthodontic problems, and we've got a huge number of kids turning up to orthodontists with airway problems. I don't know anything about teeth. Orthodontists don't know anything about taking out adenoids. So let's just, work together and let's have some mutual benefits to it all. And that's where, I actually have to disagree with the sleep medicine doctor. We're not trying to turn everybody into sleep medicine doctors, but we are trying to get a lot of people skilled up enough to be sentries at the gate, to have some sense of this child needs to turn left and this child needs to turn right. This child is seemingly doing just fine. This child, we've got some red flags and concerns. We don't need to be the person that's diagnosing what the cause of those problems are. We don't need to be the person necessarily that's dictating the treatment outcomes, but we need to put them in the hands of someone that can do those things. So I think this initiative of the airway screening task force, which was bemusing to me because I think along the way, unbeknownst to many of the committee members, quite a number of them were actually contacting me and seeking my thoughts and input on this all independently. So when I look through this, I'm going to delude myself that I can read some of my stuff in terms of what's in there. And then to have that initial screen and then the subsequent screen, I think is absolutely important. And this is what it's all about. It's about interdisciplinary treatment. A child turns up to the ENT, we can get the airway stuff better, but we need the dental team to get the skeletal bits better. We need the myofunctional therapist to get the body workers or whatever. We need to get the muscular and the neurological system working together as well. If we just act as plumbers and just unblock the drain without any form of rehabilitation or any further form of optimization of skeletal growth and development, we've missed an opportunity we can do well, but we could do even so much better. So I think the more that, as you say, we can be joined at the hip and get this O2 happening for the sake of O2, the better. And this really is what it's all about. And in particular, I think we want to focus on number 3, 4, and 5 here, because that's how we fit into this conversation from a dental point of view. When we look at obstructive sleep apnea and its cardiovascular outcomes, there's definitely good evidence that shows that having obstructive sleep apnea is bad for your cardiovascular system, whether that's your blood pressure, whether it's the way your heart works and so forth. But what's interesting is when they look at the effect of CPAP on those cardiovascular outcomes, it has a minimal effect. And I think a lot of that is because CPAP as a treatment, it has two issues. It is a very effective treatment, but because it is used so little, its efficacy, which is basically a representation of how well does it work as an entity, which is reflected on how much is it used, is not that great. And like you said, and you showed your numbers, I mean, I've got to be honest with you, I think those numbers are actually a lot better than world standards. We have a 30 to 40%, PAP adherence rate. So, we have a, 60, 70% abandonment rate with it. And when we look at the research as to why people don't continue with it, the things that are on that list include things such as poor education, poor patient motivation, lack of understanding as to what's going on and why it's important for them. And then simple things from an ENT point of view, a blocked nose, large tonsils, a large tongue. These things all compromise the use. And then, this is where oral appliance therapy actually scientifically, which is not as effective as CPAP. It doesn't work as well as a one-on-one treatment. But because patients are far more compliant with it, its efficacy actually surpasses CPAP in some studies. And the splints actually do show improvements in terms of cardiovascular outcomes. So from that point of view, we're talking about big changes there. So, and I think, as you said, we need to actually get a combined approach. I think this argument of CPAP versus a splint is actually misguided. Do both. Get the splint in, open up their oropharyngeal airway. The CPAP doesn't need to work as hard. And then, and that's where the surgeons come in. We can optimize the plumbing and so forth. And you're absolutely right again. And, it's amazing what comes up in a consistent basis. We get the best outcomes surgically from a sleep disorder breathing point of view in kids under the age of 6. We look at neurological outcomes and so forth under the age of 6. We get some interesting side effects, which people debate and discuss. We start to see resolution of things such as cross bites and open bites, and improvement in maxillary transverse dimensions, particularly in children under the age of 6. So there's definitely a time critical point where we can get even better results the earlier that we're getting in. So if we can find these kids and guide them in the right direction early, collectively we can make such a huge difference to them all. So I think you had a case or two that you wanted to share, Bill. I think that'd be a great sort of time point to do that. If I guess like to do that.
If y'all want to send questions, David, I think I don't know how many people we got online. We had about almost 1,000 sign up. So that was
we had 1,000 sign up, and a lot of them are going to be on a delay. So I can tell you, we sort of peaked just under, I think it was 180 joining us right now at the moment, Bill. So
good,
which was not bad, given it's quite early in the morning here for some. And
it is,
and so forth.
Kind of all over the world here.
Yeah.
This is an interesting little, and I can show these cases with our eyes because the eyes are an important part to look at this. I get have them sign releases where I can see that, so don't get upset that I don't have the eyes blocked out. But this is a child that came in to me. He was about, I think he was 10 years and 3 months when I first saw him. And most orthodontists will look at a 2D pan like this and then look at the cephalometric. He's kind of he's in the mixed dentition, still got a few baby teeth hanging around here and there, but he's still got teeth that his eye teeth here have not come in, or his cuspids have not come in yet. The bite back in the back for the lay people, that's almost like what it's supposed to look like. You can see how the upper teeth kind of fit in the V's of the lower here, but he's got a little bit of a retrusion. You look at it and you say, well, his upper teeth are sticking out. In probably fact, his lower teeth are sitting back, but you can see there's a deep bite where his lower teeth almost disappears. He's almost hitting on the roof of his mouth when he chews up here. So that's not good. But if you look real closely, he's got wear on his teeth. You can see these little shiny spots. He does what we call Brooks his teeth, or grind his teeth at night. And that's been related to trying to open up. It's the protective mechanism of the body to open up the airway. That's what we're understanding now. It's in the sleep world, it's just like restless leg syndrome. That's how they classify it, in the same category. So these kids that are grinding their teeth at night, it's not just because they're not stressed. I mean, what do they got to be stressed about? Not a whole lot. They're taken care of pretty well, unless there's other issues. But most of that's because they're trying to open up their airway. So these are kind of the orthodontic things that are going on. But basically, I would say probably 9 out of 10 orthodontists, or 95 out of 100, would probably just put him on a recall. Let's see him back 3 months, 6 months, a year or so. These are his 12-year-old molars. These are his wisdom teeth. Those are his 6-year-old molars that came in when he's 6. He's still got some primary teeth hanging around. So, these second molars are not even in yet. So a lot of orthodontists would just wait until all the second molars and everything comes in. Now, at this age, at about 10, about probably close to 85% of his facial growth is already completed. At the time, if we waited, probably 95% would be completed. So here is his airway. Now, I'm not going to get into the numbers real quickly, but I'm going to say, now you can't diagnose a problem with this is called a cone beam CT. It's a 3D image, but it gives us airway and it gives us TMJ and all these things in one image. But this number here, upright and awake, now he's upright and awake, so this is kind of the best airway he's got, is the way I look at it. And Dr. Schindel at Stanford, they did some studies on what's kind of normal for the age. Normally that should be about 87. So you can see it's about 78% of normal, and it's way down deep. The minimum cross-sectional area there, well, that's just the area of that is 68.3. It should be about 103 if we kind of look at that. We can't really, and you can see, you don't like to see black at all, and you really don't want to see much red. So you can see airway-wise that it is constricted, even though his tonsils maybe are not too large, but maybe a little bit. But one little trick that we use in the office sometimes is I take a regular cotton roll, for some of you speech therapists and OMTs and others out there, that even physicians, take a regular cotton roll. It's about 37 millimeters wide, and if you place it up in the top, on the upper jaw, on the maxilla, inside the mouth, and try to go from the inside surface to the inside surface, that most kids should be about that, or up to about 42. His is 32.57. Now he has a cross bite over here. You can see he has a cross bite. These teeth are fitting a little bit better, but they are constricted. So when I look at that, that intermolar width, the width between this should be about anywhere from 36 to 42, and it's 32. So it's telling me that that's a good number to measure, because that's telling me that the whole upper jaw of the maxilla is narrow. And it's a good little way. Nurses, whatever, if you want to check that, good. Now, at this time, we were using the Bears algorithm. It's a little questionnaire that you can ask toddler, preschool age, the school age kids, and the adolescents from 2 to 18. And if you look at the question, main thing, just look at all the red ones that are in red, that a yes or not good. Okay, does your child sleepwalk or have nightmares? No, but he's got have difficulty sleeping time at bedtime. They said, yeah, he tends to get enough sleep. But the main ones down here are, does your child have loud snoring, and have you witnessed them stop breathing at night? That's a huge one. That's a big one. And they did. So if we look at the little chart that Dr. Schindel did, his airway is down, at 68. It should be, for an 11-year-old, it should be about at this level, but his is actually less than even a 6-year-old. So, that's I don't diagnose from that, but it just gives me, that's kind of the best airway they got, upright and awake. Now, the whole thing is, when they lay down, guess what? It gets better. It gets worse. And Schindel did a study where they thought people that do not have sleep apnea, it reduces about 15%, but people that do have sleep apnea, it tends to reduce anywhere from 50 to maybe 80 or 90%, which is huge. You can have a patient come in here with a huge airway, upright and awake, but they could still have a problem. So here's kind of the things I use a lot. I don't always use the ones with the screw. These are the palatal expanders, where this is actually spring loaded, and you place it in the mouth. These little shelves here help get more bodily movement of the upper jaw apart. And then this is the important thing. A lot of these studies that don't show a correlation between expansion and increase in nasal cavity, they only do an RPE a palatal expander, and they only take it out to the level of the lower teeth as they exist, you have got to upright the lower arch. You see the tongue is integrally related to the lower arch. So I use a lot of these little E-arches, which are little spring-loaded expanders. It's not expanding the lower because you can't really do it, but you're uprighting the teeth. You're actually taking the teeth and just uprighting them over the basal bone. And you're taking the upper, if they have cross bites, you have to put either these palatal expanders with the screw or spring-loaded. I like these because they're a little bit less intrusive on the tongue. But anyway, these, I even do these E-arches on the upper and lower a lot together, so they both expand at the same time. Now, this is what they look like, and you can kind of see they just kind of, they upright the posterior teeth. This is what one looks like in the upper, in a little animation here. But all they are, they're anchored to the permanent molars back here. They have a little wire with a spring. It's a really simple design. I wouldn't use this for a patient that has crossbite, but the principle is still the same. Even in the upper, you can get some expansion. I can even prove that I'm getting slight sutural expansion. It's slower, so you're not going to get the big gap that you do with a rapid palatal expander where you have to turn it. Now here he is about 8 months later. And what we did is, that's what you saw, the treatment. We took a upper palatal expander and a lower. A lot of these articles where they come out and they say, well, there's no correlation between expanding the upper jaw and affecting the airway of the nose. They're leaving the lower alone, so the tongue is still being trapped. And there are other appliances out there. There's functional type appliances, mild brace and healthy start, and a lot of those kind of things, which are I'm not going to get into those, but and there's other types of treatment that tend to bring everything forward instead of backward, which tend to improve the airway. So his airway increased 110-fold, 110 square millimeters. If you double the size of the airway, Pasquale's law says if you double the size of the airway, you have about 16 times more airflow. So it's exponential, it's huge. So you don't have to get a lot of expansion to have a huge effect on that. You see the molar width went from 32 to 38. So now I've got him, and I'm still not through with the crossbite on the upper. So I think I can get this even out a little bit further. But we expand the lower along with it. Now here is the original airway superimposed over the airway in 8 months. And you can see there's a huge, huge difference there. So it went from 68.3 to 178.9. Now that's an adult airway in a 11, 12-year-old now. And you can see over here under the little bears chart, everything went negative. He does not snore anymore. He doesn't get up at night. You can see everything kind of went toward which is good. That's what you want to see. So here's the lateral view. You can see the TMJs, see where they are. We didn't affect those. So basically he started out up here with an airway that was less than even a 6-year-old. And we took him to about a 15 to 17-year-old airway. So his airway increased. So yeah, maybe you could argue some things, but the bigger the pipe, the more flow you got, the more water you can put through a bigger pipe. Fire engines don't have little bitty hoses to go put out fires. They got big pipes. And so air and water kind of act the same way. Do you want to discuss?
Yeah,
I've got some others. But
yeah, I mean, that's just an amazing and fantastic outcome there, Bill. So I recall, and I think I've shared this with you, I was at a pediatric ENT meeting be 2 years ago now. and one of the speakers was describing, adenoids and tonsils as the treatment, and then just had one slide where they put a picture up of an expander, and it was a rapid maxillary expander, for those that know what we're talking about, but something that opens up the jaw for those that don't. And the comment was to the effect of, I'm starting to see more of these. I'm not sure what it's about, but it's something to do with pushing out the teeth. And this was 2 years ago, high end, United States, pediatric ENT perspective. And I was sitting in the room going, I think I know more than most of these people, because I know that's got more than just pushing out the teeth.
Yeah.
But I think that's also part of the problem when people talk about expansion, is they only talk about the transverse. So they're taking the maxilla outwards. You've got to bring that maxilla forward somehow too, because part of what we know is the issue is that the size of the nasopharynx. So the smaller the nasopharynx, the smaller the space behind the nose, the bigger these problems are for the kids. And people, as you said, talk about nasal resistance and the lack of changes. My personal take on it, and this is truly just theoretical, is that when we go and take the adenoids out, so we're having a look, we're actually visualizing the postnasal space in a backwards way. So we're looking through the mouth up into the postnasal space. So what that means is that we're actually looking at the choanine, which is the transition between the nasal cavity and the nasopharynx. And in a lot of kids, they've got these maxillary constrictions, they've got slit-like choanine. So I think part of the reason that you're getting your expansion is not because you're improving nasal capacity, but you're actually opening up those choanine. And I don't think that's been very well researched or studied at all. And I think, one of the reasons why we get the problems that we get with the expansion is because people are not opening things in the 3 dimensions that they need to open them in. And again, I am not a dentist. I'm not the person that can, make these decisions on which kids get what and why and how. But I think this case and the before and afters speak volumes to really how you've changed this kid's life. And I'm sure you could take some nice pictures and show everyone the teeth look great as well. But you've put beautiful teeth into a child that's going to have a different outlook on life. And I think that really is something to be commended and applauded for in terms of, these sorts of outcomes.
Yeah, absolutely. This next case, if we got time.
The crowd's hanging on, so we haven't lost interest in us yet.
Yeah. Okay. This is a little child I showed you right up at the first. He was, let's see, sorry, man. Well, it got kind of, let me go here. Excuse me. This little child came in to see me. He was, took about 1.5 years in his phase 1 treatment. But if you can see he's got significant crowding. He's still not lost all his baby teeth, but he's got a real narrow upper arch. This is real narrow. It's actually V-shaped looking if we were to look underneath him. But you can see his cuspids or his eye teeth are really crowded out. He doesn't have a lot of room. He's got a lot of baby teeth under here, or primary teeth. He's got his bicuspids and everything's erupting. Again, back 20 years ago, 30 years ago, I'd have waited on him and said, hey, we'll just deal with it later. It may be a surgery case. Some orthodontists might just say, hey, look, this is a surgery case and we're not going to be able to help him until he gets a little bit older. Well, I look at this and say, no, that's not what I want to do. His minimum cross-sectional area was 83. At age 10, it should be around 100. So his airway is about 83.5% of what it should be. You can see all the crowding of the teeth up here. And then if you look, this is the This is actually his after treatment. If I can move this over, I'll show you what we did in just a second, but his airway went from 83 to 179.3. So again, he's at 11 years of age, which the airway should be about right in here somewhere. We took him up to here. He's now got an adult size airway. To me, I wish I'd have treated him even a little bit earlier. But here's the teeth, and I want to show you kind of the relationship while this works. The one thing that's missing here is the tongue. So you got the tongue inside here, you got the airway multicolored, and all these are the teeth. And if you look, as I said, that upper arch is kind of V-shaped. It's real narrow on the upper. And if we look at the remember his intermolar width between his molars is 29. It's supposed to be 36 to 42. That's huge. Very narrow arch. But you can see the interrelationship if the tongue were sitting in there. If the tongue doesn't have enough room to go, where is it gonna go? It doesn't have enough room. If you look underneath here, let me see if I can get this thing. There you go. Hard to get it just right. But you can imagine where the tongue is, and then it's blocked. There you go. And then here's the airway. So the whole point is to expand him and move the lower jaw forward to make room, to give more room for the tongue, give more room for the airway. So here's his intermolar width, 28.7. I mean, that's very, very narrow. Now you can see how V-shaped that arch is. So if you put a cotton roll up here, the cotton roll is going to stick out way over here. Now look, this is what's interesting, and I want to, for the doctors in the crowd, I really want you to look at this. I noticed this a long time ago, and I don't know what it means, but I'd like to explore it. Look at the level, look at the constriction of the lower arch where at the 6-year molars. These are his 6-year molars. These are his 12-year-old molars. These are his wisdom teeth. Now look how far out the second molar is and the wisdom tooth is compared to the other part of the arch. My question is airway and tongue position, is it affecting just this part? In other words, if I look at this, should those molars be out here? Well, look at the amount of bone that's out there. Yes, definitely. So you have to expand the lower early, and then you create room in the back, you're going to create room in the front. I'm not going to get into the expansion of cuspids argument and all that kind of stuff right now. But this is the only thing you can really, and I'm a big advocate of cone beam CT imaging. I couldn't practice without it because I would have so many questions and so many unknowns without it. But you can see how the arches are. So the lower is screaming for me to upright and expand, especially the posterior teeth, and expand the upper, the maxilla. But you can see how the other thing is how low the tongue is not sitting up in the roof of the mouth. The tongue is sitting low. This is one needs myofunctional therapy. They need to get expanded. They need to get their tongue where they're swallowing up to the roof of the mouth. Here's his before and after airway. Now we did a mandibular advance. We did a transverse expansion with a palatal expander on the top, the one with the screw that you turn. And we also hooked up what's called a Herpes mechanism that has bars, and it actually moves the mandible forward. The only problem with some of these type treatments is it does tend to bring the upper jaw or the maxilla back a little, so you kind of have to be careful with that. There are other techniques out there using twin blocks and even what's called orthotrophics to get the upper jaw and lower jaw forward. And if you actually measure some of the cephalometric numbers on this, his maxilla is actually sitting back and his mandible's back. So actually both of them need to come forward. Again, mimicking MMA surgery. Now his airway went from 83.4, normal should have been 100. The progress went to 100, 79.3. If we had let him grow and he normally grew, that airway would have gotten to 116. So there's a huge difference here, and you can see the airway. All I did was expand. You can see my expansion. I've got almost 37 millimeters of width here, and the lower jaw's forward. It opens the airway up. Now, here's the progress of where he started. The progress, and right before we start in his braces, and you can see he's a handsome young man now, not breathing through his mouth. His grades improved dramatically. It's amazing what you see happen to these children. And these are all 3D facial images, which I take on all the kids, but you can see a huge difference in it. Here's a beautiful face, and we're going to make beautiful teeth out of it. Oh, by the way, we got a good airway too. How about that? That satisfies the ENT. That satisfies the orthodontist. The other thing is with these 3D images, I look at the allergic shiners under the eyes. David can talk more about this too, but the allergic shiners are dark circles. Now, these are not too bad, but I've seen them a lot darker than that. But look at the dark circles under his eyes. And I think this was about 8 months or so, or a year and a half later, they're fading away. And David can kind of talk to you about that anatomy and what's going on there. Here's his 2 questionnaires. He's got all yeses everywhere. Witness snoring, witness stopping breathing. These are the 2 big ones. And then look, about a year and a half later, with just that treatment, I haven't even finished his braces yet. So we're gonna get a little bit more forward movement with the upper jaw. But look where the answers went. Everything negative. He didn't think he was getting enough sleep here. She does think he's getting enough sleep here. He does too. I can get into this if you want me to. Do you want to discuss this case a little bit from an ENT aspect?
I think it's pretty good actually, but I think it speaks for itself. I mean, I think anyone that can appreciate what these images mean will be extraordinarily impressed. It's just fantastic outcomes. It really is, and it just highlights, as an ENT, I couldn't get these results. I couldn't do that sort of thing to the airway. I can make the most of the room that's available, but you're actually making the room bigger. So you're turning the broom closet into a living room, literally a living room. Intended double meaning there. You're giving this kid a life that they would never have had if they had just bounced through.
His whole personality changed. It blew me away of what. Yeah. And then, so the thing about it, some parents are a little bit sketchy now about getting their tonsils and adenoids out.
For sure.
And if they do, and they just kind of say, well, I'm not, we're not going to go there. Then I say, well, when I look at it, I say orthodontically, then I've really got to get the room bigger.
Absolutely. So
at least if it's crowded right now, if I make the room, I'm going to go a little bit bigger than maybe I would want to. And then, at 12 years old, maybe they shrink back. But you don't want to wait until this child gets 12 or 14 when they say, well, that's the time the Scammon curve, drops off and the lymphoid tissue starts to decrease at 12 or 14. What happens in that first 12 years of growth?
Yeah.
They got
the years of growth, but also the years of oxygen deprivation too.
And oxygen deprivation and brain changes and cardiac changes. Yeah. So to me, it just doesn't, it just doesn't add up.
No, look, this is what I love, Bill. You and I are so much on the same page because we're about to say the same thing.
Yeah.
So, please, continue. I think this is a great.
This is something I'm working on, and actually, it's kind of proving my point. I'm big about taking 3D images of the face in addition to the bones and the teeth with the cone beam. But I've always thought the face tells you a lot of stuff if you'll just analyze it. So patients can tend to have these dark circles under the eyes, maybe the bags under the eyes, small nose, open mouth, breathing. This group actually in Australia, on the other side of Australia, took this 3D MD camera, which is what I have, and they located these landmarks on the 3D face. And you can see the predicting sleep apnea from 3D facial photography. Now think about this. Think about taking this into schools and doing this on kids, and it being able to maybe recognize some potential issues. It's not diagnostic, but at least it's something that may be pretty good. What they did is they connected these landmarks, straight line measurement, just straight as the crow flies, between different types of measurements, and they measured them. Proportionality, don't worry about all the, these are called geodesic lines. These are, it's connecting point to point, but it's over the surface, like you're going up and down the hills, and that's a different measurement. Now, when they added these two together and analyzed them, all I want you to look at is this top line. It's about 90-something% sensitive. It's not specific toward it, but it's sensitive enough at almost 90-something% level that it's predicting potentially sleep apnea. That's a huge deal. So it's something I'm kind of working on. So it says here in conclusion, the main findings of this study was that the geodesic lines, these are the lines that kind of go over the surfaces, and the linear measurements to identify patients that have sleep apnea, or maybe even sleep disordered breathing, from 3D photography of the face. Results suggest that it might be possible to predict the severity of an individual that has sleep apnea with facial photography. Now, that'd be huge. There was another study done about autism, and they could actually take children early on and predict what kind of, if they have some autistic traits. Autism, I'll let David kind of explain it a little bit more than me, but autism is one of those things where it's kind of more testosterone is put out early in life, and you get more of a masculinized face. In other words, if we look at if normal female faces, just bear with me with the graph of the people that are maybe layman out there, but basically this would be normal, the normal curve of female faces. So the more you toward this part of the graph, it's more masculine, and the more you go this toward the graph, it's more feminine. So these are the females, and you can see they're a lot more feminine. That's the average female and the average male. So this is what male faces look like, but they're all more, the males are more masculinized. The kids that have autism, here are the faces of the autistic females. You can see there's a shift toward masculinity. Here's the male counterparts and how it shifts toward masculinity. So they think it has to do with testosterone levels and that. But anyway, just another predictor of something that can be done with facial photography. I won't get into all that. This is a study that I really think is interesting. Dr. Richmond, Steve Richmond, and Ali in Cardiff, Wales, they took the 3D camera, and they took almost about 1,724 children that had documented sleep disordered breathing, not with polysomnography, but with screening exams. And they put them all together and created one common shell. They took 1,862 healthy, all these were 15-year-old children, and they made a common shell of that, and they put those two shells together. And what this shows is the difference between those two common shells of those kids. And if you look, everything that's pink is at the same level. Both of them were at the same level. Anything red is more prominent, anything that's blue or darker blue is away from you, is recessive. So these sleep disordered children, what did they have? They had it's not just the maxilla that was recessive, it's the whole nasomaxillary, as Kevin Boyd says, respiratory complex. That's what that is. That's the nasomaxillary for upper jaw, naso for nose, respiratory for breathing. Here's the lower jaw. It's down and back. It has an integral part that it plays also, especially if it's back. If everything's back, this is just screaming to me that everything needs to come normal, comes forward. Even patients that have overbites or class 2, as we know, may actually have recessive maxillas, and it's a trick, but there are ways of doing that. Now, the one thing that I found interesting, that first observation I made, I took a transverse plane and I'd cut down through the face, and it would give me that basically kind of geodesic line that's over the surface. But if you look real carefully, and I find this almost 100% where the left side of the face is flatter than the right. Now look at their data set. Same thing happening. Isn't that interesting? I don't know what it means. I don't know, it's something that David and I need to explore, but I see it all the time. And we can get into this if you want to. This is kind of, to me, explains the difference between early treatment and waiting till they're in a different part of the body. You take a child that's got clubfoot or pigeon-toed, what do? 1 month or 3 months at the most, they put them in casts. They mold their legs, so when they grow up, this child goes to here and they start walking, guess what? You can't even tell they had a problem. And then when they grow up to adulthood, you can hardly tell they had a problem. You're not going to wait for this to go in and start. You're just not going to do it. So to me, the bones are different, and you can argue all that with me all day long. But to me, this tells the tale of what it should be. And we should be looking at them early, even in the baby teeth. If they don't have spaces and everything's kind of pinched in, that's probably this is kind of the earliest stage I would want to get them. I put little expansion arches, and it's just like butter. I mean, they just open up so good, and the airways get so good quickly. This is what parents come in and say, and they say, my child had such pretty baby teeth. And then all the ugly old permanent teeth come in and mess everything up. Well, they just don't have room. You want spaces, a lot of space is what you want in the primary dentition. And then we can get into lingual frenums and all that. I'm not going to get into there, but that's the other parts that we got to deal with. Let's stop on that one. This is another case we can go into, but maybe we want to stop and do a little discussion right now.
Yeah, I was going to say, we probably got a good audience still, Bill. I'm surprised that we've actually, I've just checked the time. We've been going for over an hour, and as you and I know, we could be here all day and still just be fascinated with everything you've got to share. What I might do is I'll just give people a heads up. So it's going to take us a while, but Bill and I are actually collaborating on a book. We want to bring our collective knowledge together. And as you can see, Bill's got an amazing amount of knowledge that he's bringing to the table. So I'm really humble that he's brought me on board with the project that he's wanted to do for a long time. So we'll keep you posted on that. The other thing that, you can sort of give me an indication on the comments section when you get the chance, is that Bill and I are entertaining the idea of doing some lecture series, doing some webinars. I know we're all a little bit webinared out, but just basically, trying to do this sort of thing, but sticking to a particular topic. So we'll have a whole range of topics, and we're going to focus on sleep medicine, medical and dental. It's wrong to call it sleep medicine, because medicine implies it's a doctor thing. We need to find a commonality term. And I know we talk about dental sleep medicine as if it's something special, but it really is. It's all one and the same. So again, if people have sort of got an interest in Bill and I doing that, these things take a little bit of effort and work. So obviously we want to make sure it's of interest to people, so they can keep an eye on that. I've got my Facebook open here, so I can see if people are making comments. Just give people, if anyone's got a question or anything they want to clarify at the moment, now's the time to start typing in the comments section. If everyone's good and so forth, I just want to say a huge thank you. We did have nearly 1,000 people say that they were interested, and a lot of people are in time zones where they're not actually joining us live at the moment, but I've recorded this and I think hopefully Facebook will keep it as well. But if not, I'll post it into YouTube and then link it through YouTube onto the page just as a backup. Look, just thank you so much for people taking the time just to hear what we've got to say and just take on you know, the information and knowledge that we wanted to share with you all. So that will conclude proceedings pending any questions. So far it's all pretty quiet on the Western Front there, Bill, so we might find that people have got a good amount out of there, and we've been, you know, thorough enough that they don't have any specific questions they want to throw our way, which is okay. So that being the case, if you want to sign off with anything at this stage, we will bring it to a close.
Okay, good deal. I enjoyed it. Thank you for bringing this together and making it work on Facebook. That's great. Hope everybody had a good time. Yep,
excellent. All right, guys. We'll thank you again for joining us, and then for those that weren't live, you'll enjoy what we've got to share in due course. And then, as I said, you know, keep your eye out for a book, and then if there's interest for webinars and the like down the track, we've got a huge amount that we can offer, I think, between the two of us, in a simplified version that's also comprehensive at the same time. So I'll thank you all again, and on that note, Bill, we will call it a day.
Yep, have a good time over there. It's in the morning here.
Yeah,
it's in the morning there.
It's morning here, just the day starting as yours ends.
Yep. Yeah. So we'll good. We'll talk to you later. Thank you.
Will do. Thanks again.
Enjoyed it. Thank you. Bye-bye.
Bye.